Hi, good evening, everybody. Good afternoon, good morning, wherever you are. Welcome to this monthly webinar. This is the October webinar of the International Academy for Clinical Hematology. You may have noticed this is a very busy week for us because this week we have launched the Junior Club, which took place on the 17th of October. We launched yesterday the Innovation and R&D Podium, which took place yesterday on the 18th of October. And today we're together live for our usual monthly webinar with a top expert, special guest, but also a very good friend, Dr. Pau Montesinos, who is from Valencia in Spain. From the Polyclinique La Fe. And this is a very famous place, but most importantly, Pau has dedicated all of his career, I think, to acute myeloid leukemia, to clinical research, to advance the field of AML. And he has pioneered some of these trials which have used targeted therapies for the treatment of AML. And we're very proud and honored to have him today. He kindly accepted to tackle today a very hard but very exciting topic, which is about the treatment of relapsed refractory IDH mutated AML. And you may remember that we have now IDH1 inhibitors, IDH2 inhibitors, which are approved. They may not be available everywhere, but Dr. Montesinos is really the best person to give you the state of the art in this field. And of course, this is a live educational activity, so please do not hesitate to share your questions and your comments, your suggestions. And we'll have some Q&A at the end of the webinar, and I'll do my best to share your questions with Dr. Montesinos. But for now, the floor is yours, Pau. Please, you can jump in.
Thanks a lot, Mohamed. Merci beaucoup, my friend and my colleague. It's for me a pleasure to be here this afternoon in Valencia, in Spain, and in Paris, in France, and in this webinar again in this very high activity group of International Academy of Clinical Hematology. It's an impressive sustained activity, and it looks like growing as well. And yes, thanks for the introduction, and I will take the next 20-30 minutes to give you my vision of what is going on in this disease, in the very hard to treat relapsed refractory AML, and in particular we will focus on IDH mutated patients. So first of all, you know that the therapeutic ground and the knowledge of the disease in AML has improved in the last decades, in particular in the last 10 years. 3 decades or even 2 decades ago, we were treating all patients with using the one-size-fits-all therapy. This means all patients were receiving intensive chemotherapy or nothing, those that were not eligible for intensive approaches. Then we started in the later 90s and first 2000 to treat patients with tailored therapies. This is acknowledging the risk factors and predictors of response and of relapse. So we were intensifying post-remission therapy using allogeneic transplant or continuing by chemotherapy consolidation only for low-risk patients or high-risk patients, respectively. And now we are moving to the targeted era. We are deep inside. Another thing is how this availability of new targeted agents are really changing the treatment paradigm and the disease history. I think that in general, we can say that in the front line, when these targeted agents are used, they could be more impactful on the disease evolution. But when they are used in the relapsed refractory setting, then it is much more difficult. But even though our patients are already benefiting from these targeted agents as well in the relapsed refractory setting. And it is important because patients, they may have different opportunities of treatment in second, third line, even fourth line, opportunities that in the past were not available for them. And this is thanks to targeted therapies, at least in part. So regarding IDH mutations, these are gain of function mutations. There are enzymes that are included in the metabolism of the mitochondrial respiration and metabolism, and this gain of function is leading to accumulation of 2-hydroxyglutarate, which is an oncometabolite and which is affecting transcription and differentiation of myeloid stem cells. So this is a leukemogenic event. And it has been identified IDH mutation in roughly 20% of patients, more or less 10% can have a IDH2 mutation, 10 to 15, and 7 to 10% they might have IDH1 mutations at diagnosis, and these are druggable mutations, and both represents around 20% of our patients, which nowadays can benefit under different circumstances from targeted therapies. These are data from a PETEMA diagnostic platform for AML. Is a national network in Spain, and this is to show what you know, but that IDH mutations overall are present in 23% of the samples that were analyzed, and there is a difference in the distribution by age. We find that IDH2 mutations in particular, but also IDH1 mutations are quite more frequent in older patients. These are mutations affecting methylation, and so they can be more associated to older age and to even to secondary AML. And we see here in this graph how IDH mutations, they are more frequent, roughly 35% of patients at relapse or refractory resistance, 24%, and relapse 35%. They harbor one of the IDH mutations. So this is some instances reflecting two things. First, that these are more frequent mutations in older patients, which will have more resistance and more relapses after frontline, usually with azacitidine, but nowadays as well with azacitidine and venetoclax combination. And this is also reflecting that maybe in younger patients, and especially regarding IDH1 mutations, these are related with more relapses and worse prognosis even once the relapse is coming. This is important. You know that AML is a heterogeneous disease with different clones frequently, but also with commutation patterns. And the prognosis may be different regarding with the same baseline mutation, but according to different commutation patterns, the prognosis may change. For example, it is well known that IDH2 mutations, when they are associated with SRSF2 mutations, they have worse prognosis than IDH, for example, IDH with NPM1 mutation. As well with IDH2, we know that R140 isoform is intermediate bad risk prognosis in general, but IDH2R172 is a good prognosis, although less frequent mutation isoform is better prognosis, and it looks that it is more chemosensitive. So the question is, this is a graph from the SAL group German by courtesy of Christoph Rohlig. So the question is whether or how much we can wait to have genetic information and in particular mutation status before starting therapy. So this is upfront therapy data in younger patients or more than 60 years old patients, but all treated with 7+3 regimen. And it looks that waiting too much could have deleterious effect on the prognosis of patients, and younger patients where starting therapy is delayed, they can have worse survival. But it looks that in older patients to wait in the front line, this is not so is more acceptable. There are no differences regarding patients where starting therapy was delayed or not. In my opinion, once it is clear that we need to start one therapy, what is the therapy that we select? Once it is clear, we need to start as soon as possible in AML patients. However, we don't really have data in the relapsed refractory setting on how it is advisable to delay starting therapy for patients. It is possible that as well to delay in excess the starting therapy may lead to more mortality of patients because of hemorrhages or infectious complications mainly. It is true that at the relapsed refractory setting, many patients, they don't have a high burden disease because we can detect relapse at early stages with low burden. So maybe there is more room for delaying therapy. And in particular, in the era of targeted therapies, we are used to delay starting therapy for patients because we have some targeted options, and we need to have the molecular diagnosis before starting, for example, one IDH inhibitor. So it is the rule in the relapsed refractory setting to wait much more than in the frontline setting. Regarding the rechallenge or retesting of mutations, it is important. In particular for FLT3 mutations, they are unstable. So patients on initial diagnosis, they may have FLT3 ITD, for example, or TKD, and that relapse they lose in 30% roughly, or even more now under midostaurin frontline application. But for IDH mutations, in general, we know that they are much more stable, but it is necessary to rechallenge the mutation status of patients at relapse refractory. We cannot treat a patient without retesting and having the molecular diagnosis with the disease at the time of relapse refractory. There are newcomers in older patients, azacitidine plus venetoclax. We know that patients with IDH mutations in the front line are responding quite well with a high rates of response. However, the vast majority of patients will relapse early. I think that probably IDH1 mutated patients, they have a little bit less responses than IDH2 mutated patients with this regimen, and they are poor prognosis, even using venetoclax and azacitidine. And unfortunately, when we go to the real life evidence, that there is not a lot published, but we have some new, this is 2022 researches, except of this one, 2019. But in the real life, it looks that azacitidine and venetoclax, HMA and venetoclax are not really changing the disease history. They are for sure more effective in terms of complete remission and as well in durability of response and deepness of response, but by the end, the prognosis of older patients is still dismal. So we need to improve. One potential improvement, this is IDH 1 with ivosidenib plus azacitidine in the front line. So this is an interesting option with high complete remission rates and as well improved survival. We don't have head-to-head comparison regarding azacitidine venetoclax in the front line, but I think it is important to know that this option, and in fact it has been approved, this combination in the front line by FDA. It will take several months, or I don't know if years, but months at least, to get approval in Europe, but it may have an impact in the relapsed refractory treatment. The reason is that IDH1 mutated patients, if they are treated frontline upfront with azacitidine plus ivosidenib, then if they lose response, which will happen unfortunately in the majority of patients by the end, and they will relapse or they will not respond, so they will not be treated in the relapsed refractory setting with more ivosidenib in monotherapy. This is logical. So in the relapsed refractory setting, we need to make the difference between older patients and fit patients, of course. Unfortunately, the outcomes, this is a meta-analysis, systematic review of the literature, but unfortunately in those patients, overall survival in median is not very different between non-intensive approaches like azacitidine, around 9 months, 8 months median overall survival, and for example intensive approaches like FLAG-IDA or FLAG with roughly 8 to 9 months as well of median overall survival. And the complete remission rates, of course, there is a big difference there. The there is a problem here in this bar, but intensive chemotherapy approaches like MEC or FLAG-IDA or CLAG, they can reach roughly 40 to 50% of complete responses. However, non-intensive approaches like azacitidine, they may reach around 15% or even less of complete remissions. However, the median overall survival is similar, okay, but it is important that we approach younger patients with treatment options that will allow more possibilities of complete remission. So in that case, it is intensive chemotherapy, FLAG-IDA, for example, or Mylotarg-containing regimen, probably 50% of complete remission, and then to perform a subsequent allogenic stem cell transplant, because even if median overall survival is poor, or roughly 9 months, we will have around 20 to 30% of long-term survivors if they achieve complete remission and they are subsequently allografted. So this might be the objective, the goal in younger fit patients, to achieve complete remission and then to perform salvage. And this is applicable, of course, to IDH mutated patients. But we have alternative options nowadays, not only intensive chemotherapy, as azacitidine for unfit patients. We have targeted therapies. These are the phase 1 main outcomes, main results. It's a study published several years ago with a significant number of patients, 179 patients, and complete remission, CR/CRh rates were 30%. This is a really very good data with chemorefractory patients, usually, that are included in this kind of trials with oral agent in monotherapy. We can achieve 30% responses. This is very good, and 40% roughly of overall responses, including CRi. And those patients could be allografted subsequently, maybe. The toxicity of this drug in monotherapy, the main toxicity is IDH differentiation syndrome. It is not a full-blown syndrome, usually like acute promyelocytic leukemia with differentiating agents. This is because IDH inhibitors are working not by cytotoxicity, but mainly through differentiation. So this is the side effect. Also, ivosidenib may lead to QTc prolongation in grade 3 in up to 10% of patients. But this is not life-threatening usually, but we need to monitor. We can have leukocytosis of clot, we can have bleeding, side effects that are similar to standard approach in salvage therapy. However, the overall toxicity profile of these agents is quite more friendly than intensive chemotherapy without mucositis, without deep myelosuppression. In fact, many patients, they even do not present neutropenia after these therapies. So these are manageable agents, but we need to keep in mind that they may have drug-drug interactions and they could lead to QTc prolongation, and in particular, treatment of differentiation syndrome should be started, like in APL when there is a suspicion of the syndrome. Median overall survival was 9 months, which can be in line with the rest of the therapies, in fact. But we see how the responders, they have, of course, better survival, and some of them, they have mutation clearance, which is important, but it is not necessary really to have long-term survival. That we can see some subjects that they have sustained their responses with monotherapy. And this is, in my opinion, impressive. There is no phase 3 trial with ivosidenib in relapsed refractory compared with standard of care, but there was an attempt to perform a comparison with a much better analysis with a synthetic historical cohort from different registries, different institutions. My institution participated in this study, for example, also German group, and they compared real-world data matched to the phase 1 data of patients treated with ivosidenib. And this was a presentation that I had, has not published. I think that probably the reason because this has not published is because overall the results were not quite positive, except for non-intensive patients. So we see that as compared with the real-world series matched, those patients that were treated non-intensively, they did much worse than ivosidenib. However, patients treated with intensive chemotherapy in the real world, they did equal or even better than ivosidenib. Enacidenib is an IDH2 inhibitor. These are data from the phase 1 study. Similar in general, rate of responses 40%, 9 months median overall survival, IDH differentiation syndrome. There is no QTc prolongation. There are no drug-drug interactions or no relevant drug-drug interactions, and enacidenib is much more easy to handle for the treatment of these patients than ivosidenib because of no drug-drug interactions. And we see the timing of response. This is similar in ivosidenib as well, that patients are not achieving responses in general after 1 or 2 cycles, but it can take 3, 4, 5, even more cycles to achieve a complete response. But as there is not, in general, a lot of myelosuppression, so this is relatively tolerable treatment. But patients should be managed carefully, of course. And there is a randomized trial, the IDENTIFY trial, comparing enacidenib in monotherapy with a pre-selected option by clinician as azacitidine, low-dose Ara-C, best supportive care only, or intermediate dose Ara-C. This was for second line, third line or more, and 60 years old or more patients. So it's a very, very difficult to treat population. This is a trial where it was really very difficult to expect any kind of improvement. However, the trial showed even tripling the response rates with enacidenib salvage as compared to standard of care, low intensity in general. And however, the trial was negative. So the trial overall was negative, and this was in the particular effect of patients pre-selected or treated in the control group with intermediate dose RAC. That was not considered a non-intensive approach. So in those patients, intermediate dose cytarabine was better or equal than enacidenib monotherapy. However, for patients that were pre-selected and treated with non-intensive conventional care regimen, the supportive care, low-dose cytarabine or azacitidine, hypomethylating agent, there was a significant improvement with enacidenib. However, we can consider that this was a negative trial, unfortunately. There are other options to treat patients with IDH mutated relapsed refractory disease. This is important because, unfortunately, nor ivosidenib nor enacidenib had a licensing in Europe, but they are approved and marketed in the US and other countries. So there are other options off-label. This is venetoclax, azacitidine, or the cytarabine in relapsed refractory AML, and we see how IDH1 mutated patients as well as NPM1, they can still show better benefit than others in the relapsed refractory setting as well with venetoclax. So chemosensitivity to venetoclax is also applicable to the relapsed refractory setting in IDH mutated patients. There are other options in development. The one that is more advanced is olutasidenib, is a different IDH1 inhibitor, has a toxicity and efficacy profile very similar to ivosidenib, really, even with the long-term responders. So is a good activity, is manageable regimen as well. One difference might be that olutasidenib is going through the blood-brain barrier, not ivosidenib. These are phase 1 results with good complete remission rates and survival. This trial looked also at combination with azacitidine in the relapsed refractory setting. And this is a sub-analysis published at ASH last year by Stéphane de Botton and colleagues. This was focusing on biological markers, and it looks that when patients, they have more mutations, not only IDH1 mutation, but other co-mutations, so they tend to respond less. In particular, if patients have IDH1 mutation plus FLT3 or NPM1 or TKD mutations, they tend to respond worse. And we have new targeted agents under development. I put here the one that I know because we are participating in these clinical trials. One is a LOXO compound by Lilly, and the other is by HUTCHMED. They have different properties, of course, and the main difference to ivosidenib or enacidenib is that these agents are tested in clinical trials that are including IDH1 but also IDH2 mutated patients. So they have, or it looks that they have, and they will have clinical activity in both settings. So we will have these drugs as different options, hopefully in the future, if they go through phase 1 to 3. So thanks for your attention.
Thank you very much, Pau, for really beautiful overview. And actually, you managed in 30 minutes to simplify some very complicated issues, especially all of these novel trials that were performed recently. And it is quite amazing, actually, that for almost 40 years, nothing happened, and we had to live with 3+7. Then we had azacitidine, and recently azacitidine plus venetoclax. But now it is the era of targeted therapy, and this is reflected in these recently published ELN guidelines in Blood months ago. One question we have from Dr. Arbab is whether, in case you have an IDH mutation, I guess IDH1 or IDH2 at time of relapse, do you consider the VAF for beginning the treatment?
No. Look, we are treating patients mainly in the context of clinical trials, and usually the requirement is not that you have a VAF more than 10%, or this is not required for eligibility. I think that usually for NGS, as well for a standard PCR, the threshold of sensitivity is around 3%. Some will argue for 5% to say that it is positive. As far as I remind, in clinical trials, there is not usually a defined threshold of positivity, if it is 2% or 3%, but it is enough that the laboratory says that there is a detection of IDH according to sensitivity of the method. I didn't show you, but there are data from this biomarker analysis of the olutasidenib study showing that patients with more VAF, so more allelic burden, it is not the same, but just to understand, those patients, they can respond, they can have less responses to olutasidenib, but it is not a fine-tuned analysis, because maybe there is a more correlation with, for example, FLT3 or signal-activating lesions, and this was not really analyzed in this study. So I think that we don't have really to look at the VAF when starting therapy with these agents, just that it is positive.
Thank you. That's very clear. We have a lot of questions about combinations. Of course, I do appreciate that the development is about single agent first and in the most advanced setting, but then progressively you would like to use them in earlier lines, but also in combination. And one of the questions we had, for instance, from Dr. Zusenka Andrews, who is a very loyal contributor to the ICH activity, is about whether you would consider, and I'm trying to summarize his long question, combinations, for instance, the agnostic azacitidine plus venetoclax, and if you have the IDH mutation, would you think that adding the targeted therapy would be useful? So the question is about single agent, doublet, or even triplet.
Okay. It depends on the context. Okay, so for example, in the US, you may have available venetoclax azacitidine in front line, but you will have ivosidenib monotherapy in the relapsed refractory setting with good results. So if these options are easily available, it is reasonable to start with venetoclax azacitidine and then at the relapsed or refractory setting to switch to ivosidenib or enacidenib monotherapy because they are available. In Europe, unfortunately, it is very difficult to have access to ivosidenib or enacidenib. So we don't have so much options. And now I think that venetoclax azacitidine is a good option for in the front line for these patients. But probably when we will have ivosidenib azacitidine in the front line after the Agile study results, in my opinion, because of efficacy, we can say nothing because it is not head-to-head, but because of toxicity, less myelosuppression, I think that it is a more friendly regimen for patients. Probably the choice will be ivosidenib and azacitidine, and to give venetoclax azacitidine in the relapse for those patients. It is a reasonable option. It is off-label option, but it is widely used. In my experience, it is not my single experience, but also the cooperative Spanish group that we have analyzed and published this. Unfortunately, the results are not so good as expected. And it is like in the phase 1 of MD Anderson 6 years ago or more, it was roughly less than 20% of responses. And the survival, unfortunately, was not very prolonged. But I showed you that the IDH setting can benefit more than others of azacitidine and venetoclax in the relapsed refractory setting. And triplets, it's fully experimental. I wouldn't recommend to use.
But for instance, we have a question when it comes to combinations about those patients who may receive FLT3 inhibitor. Is there any experience with this?
Look, I think that in the relapsed refractory setting, at least in Europe, there is gilteritinib. So if you have a patient with a FLT3 mutation, this is the first option. In the US, you may face up patients with FLT3 and IDH2 mutation, for example, and relapsing. So what will you do? You have two options, okay? So this is a good situation for patients. You have two options. I really don't know what is the best option. Up front, I would probably abrogate for FLT3 inhibitor. And the reason is that FLT3 mutations, it looks that they can predict a worse response under IDH inhibitors. And maybe we can select a negative clone of FLT3 when there is a relapse, and then or resistance, but relapse at least, and then we will switch to the IDH inhibitor. But I cannot make any recommendation, and as well combination in this ground is totally experimental. I wouldn't recommend outside of a clinical trial.
Okay, thank you very much. That was a question actually from Dr. Matteo Dragani. We have another question for you, Pau, is about using the IDH inhibitors as a bridge to transplant. I know that the development has been done in the unfit patient. So in theory, the question of transplant is not relevant. However, I think people like to use these novel agents as a bridge to transplant. What are your thoughts on this story?
My thoughts is that for bridging to transplant, it might be a good and efficacious option, but I think that this should be nowadays, at least, and there is more evidence, should be given only for patients that fail intensive chemotherapy options. So, of course, if a patient is refractory to FLAG-IDA or MEC, 3+7 FLAG-IDA is still refractory, there is no sense to pursue more intensive chemotherapy options. So I think that an IDH inhibitor would be the ideal option, and with chances to achieve a response. It looks that these agents will work where chemotherapy is not working. So you are switching the mechanism of action. Doesn't matter if it was resistance to chemotherapy, it can respond to the targeted agent. So it is a good option, and it is a pity that in Europe we don't have available these agents, ivosidenib and denasidenib, in my opinion, especially for these younger chemorefractory patients that still can have an option of cure bridging to transplant. But unfortunately, it is not available, but for sure in other countries or in institutions where they have clinical trials or they manage to access to these drugs, and this is used, and this is this is a new option for patients.
Excellent. I know time is running, so we'll take one last question and then we'll let you go, Pau, because I know it's already almost 7:45 p.m. So we're very grateful. Have you ever used ADH inhibitors after allotransplant, either for maintenance or for salvage? And what is the tolerance?
We have used here for relapses after transplant. So this has not been used in the context of polymedication after transplant. I think that this is a different ground. Once the patient relapse, if there is some immunosuppressive agent, these are withdrawn usually. So the management is very similar to a relapsed refractory patient without the transplant before. So I cannot do comments on tolerability under transplant. This would be the maintenance schedule. I think that in the OVON trials with IDH inhibitor in combination with chemotherapy, there is a maintenance schedule that is also applicable after allogenic transplant. I am not pretty sure, but I think that this schedule is in the study design. We will have, if this is the case, we will have data from these studies. I am not aware of studies exploring maintenance with IDH inhibitors after transplant. I don't have. And in clinical trials where we have participated and treated patients, once they were bridged to transplant, they were discontinued from the trial.
Okay, well, I think, again, thank you very much, Pau, for dedicating some time in your very busy day, very busy schedule. I know you had a very big clinic today, but still you managed to make it with us. Thank you very much. And thanks to all of you guys who are loyal to the activities of the International Academy for Clinical Hematology. I guess our next activity is next week, and we have, I think, a nice journal club waiting for you. Just watch out for the announcement. But for the time being, I wish you a good evening, a good night, a good afternoon, or a good day. Thank you very much and take care.